Hello doctors, welcome back to Conquer Pathology with Dr. P. Today we are tackling one of the most clinically relevant chapters in all of Robbins, hemodynamic disorders, thromboembolic diseases and shock. This isn't just exam fodder, this is the bread and butter of medicine. Whether you become a surgeon dealing with DVT, an intensivist managing septic shock, or a general practitioner treating heart failure edema, this chapter is your foundation. We will cover this strictly according to the NMC CBME Competencies PA 6.1 to PA 6.7, integrating physiology, anatomy, medicine and surgery. So grab your Robbins, a notebook and a coffee. Let's conquer this. Part 1. Edema and Fluid Balance. This covers NMC Competency PA 6.1. Imagine your blood vessels are pipes and the tissue spaces are the garden outside. Ideally, we want just enough water to leak out to water the garden and then be drained back. Edema is when the garden gets flooded. Pathophysiology, the Starling forces. Normally, fluid movement is governed by the Starling law. Hydrostatic pressure or capillary pressure pushes fluid out, like water pressure in a hose. Colloid osmotic pressure pulls fluid in, exerted by plasma proteins, mainly albumin. The imbalance. Edema happens if hydrostatic pressure or capillary pressure is too high, for example in heart failure. Osmotic pressure is too low, for example in liver failure, malnutrition, nephrotic syndrome. Lymphatic obstruction, for example in filariasis or cancer, or in sodium or water retention in case of renal failure. Think of albumin as a sponge inside the blood vessel holding on to water. If you lose the sponge, as it happens in hypoalbuminemia, water leaks out. Go through this table to understand the differences between Transudate and Exudate. Part 2. Hyperemia and Congestion. This covers our NMC Competency PA 6.2. Both mean increased blood volume in tissue, but the vibe is different. Hyperemia is the active process. It's like a blush. Arteriolar dilation leads to increased inflow. Tissue is red and warm, for example in exercise or inflammation. Congestion is a passive process. It's like a traffic jam, impaired outflow. The tissue is blue or cyanotic and cool, for example, cardiac failure and DVT. Let's see the clinical morphology of the nutmeg liver. This is a favorite exam question. In chronic passive congestion of the liver, usually due to right heart failure, the central veins get congested, causing red or brown dots. The surrounding hepatocytes undergo necrosis because they are furthest from this oxygen supply. The periportal hepatocytes are viable. This is the fatty change. Gross appearance, it looks like a cut nutmeg or mottled red and tan. The mottled red is the congested part and the tan part is the fatty or viable tissue. Let's integrate this vertically with medicine. Patients with right heart failure present with hepatomegaly and jugular venous distension. The nutmeg liver is the pathological basis of that tender hepatomegaly. Part 3. Hemostasis and Thrombosis. It covers our NMC Competencies PA 6.4. Now we move to the clotting section. Normal hemostasis. It happens in a sequence. Imagine a hull breach on a ship. Vasoconstriction. It isolates the area. It is a neurogenic reflex. Primary hemostasis. They throw the sandbags at the hole. The platelet plug formation involving von Willebrand factor and glycoprotein 1b. Secondary hemostasis. It cements the sandbags. The coagulation cascade leads to fibrin mesh. Then comes thrombus stabilization and resorption, or the cleanup. Let's break down primary hemostasis. When we talk about primary hemostasis, I want you to think of one phrase, the platelet plug. This isn't the hard fibrin clot yet. That's secondary hemostasis. This is the initial rapid response to injury. We are going to cover the normal physiology, the specific receptor defects that causes famous diseases, and exactly what clinical signs you'll see in a patient. Let's dive in. Normal physiology. It all starts with trauma. Whether it's blunt or penetrating, we have injury to the blood vessel. This injury strips away the protective endothelium and exposes what lies beneath, collagen and microfibrils. Now normally, blood flow is smooth, But when endothelial cells are damaged, they release stored granules containing von Willebrand factor. Think of von Willebrand factor as the glue that lines the exposed collagen. This leads us to step 1, adhesion. The von Willebrand factor binds to the collagen. But for the platelet to stick to the von Willebrand factor, it needs a specific receptor. This is high yield. The platelet uses glycoprotein 1b to bind to VWF. Glycoprotein 1b stands for initial binding. Once adhered, the platelet gets activated. It changes shape, going from a smooth disc to a spiky sphere with increased surface area. It also degranulates, releasing pro-clotting substances like ADP and thromboxane A2. These substances recruit more platelets. This leads to conformational changes in a different surface receptor, glycoprotein 2b3a. This receptor change increases affinity for fibrinogen. Fibrinogen acts like a bridge linking adjacent platelets together via their glycoprotein 2b3a receptors. This cross-linking is called aggregation. So, recapping, glycoprotein 1b is for sticking to the wall, adhesion, and glycoprotein 2b3a is for sticking to each other, aggregation. Part 2. Disorders of primary hemostasis. Now that we know the machinery, let's break it. Pathology is just physiology gone wrong. We can trace specific diseases back to the specific steps we just learned. First, look at the very top. If you have an acquired or inherited reduction in von Willebrand factor, the platelets can't adhere to the vessel wall. This is von Willebrand disease, the most common inherited bleeding disorder. Next, what if the von Willebrand factor is fine, but the receptor on the platelet is broken? If there is a defect in glycoprotein 1b expression, the platelet cannot bind to von Willebrand factor. This is called Bernard-Soulier syndrome. Bernard-Soulier means big platelets, broken glycoprotein 1b. Moving down, what if adhesion works fine, but the platelets can't clump together? A defect in glycoprotein 2b3a means no fibrinogen bridging. This is Glanzmann's thromboasthenia. Think Glanzmann's, no aggregation. And finally, sometimes the machinery works, but just don't have enough workers. Simply having a low platelet count is thrombocytopenia, which naturally leads to insufficient plug formation. So how do these patients present clinically? Disorders of primary hemostasis present with mucocutaneous bleeding. We are talking about skin and mucous membranes. Look for epistaxis, frequent nosebleeds, menorrhagia, heavy menstrual bleeding, petechiae, tiny pinpoint hemorrhages on the skin. If you see deep muscle bleeds or hemarthrosis like joint bleeding, stop thinking about platelets, that is secondary hemostasis, which is due to coagulation factors. One quick pharmacology pearl before we finish. Look at this note about aspirin and NSAIDs. Why do they cause bleeding? They inhibit cyclooxygenase, COX, which stops the synthesis of thromboxane A2. Without thromboxane A2, you can't recruit more platelets and aggregation is inhibited. This is why we give aspirin for heart attacks, to stop the clot. So there you have it. Injury exposes collagen, glycoprotein 1b binds von Willebrand factor for adhesion, glycoprotein 2b3a binds fibrinogen for aggregation. Break any link in that chain and you get mucocutaneous bleeding. Till now we have built the platelet plug. That was primary hemostasis. Think of it as the bricks. But a wall of dry bricks will crumble if you kick it. You need cement. That cement is fibrin. And the complex factory that creates fibrin is secondary hemostasis or the coagulation cascade. This chart might look intimidating with all the Roman numerals, but we are going to break it down into 3 simple routes: the extrinsic pathway, the intrinsic pathway, and where they meet, the common pathway. Let's start on the right side, the extrinsic pathway. Why extrinsic? Because it starts with something outside the blood vessel. When you have tissue injury, the damaged cells expose tissue factor, also known as thromboplastin, to the bloodstream. Tissue factor binds factor 7. Together they form a complex. Tissue factor activates factor 7 into 7a. This complex then shoots straight down to activate factor 10. That's it. It's short, it's fast, it's the spark that starts the fire. Now, on the left side we have the intrinsic pathway. This is longer and does the heavy lifting. It's triggered by contact factors like collagen, HMWK, and prekallikrein inside the vessel. Here's the sequence you need to memorize. It counts down, mostly. Factor 12 activates 11, factor 11 activates 9, factor 9 with the help of its buddy factor 8 activates factor 10. A great memory aid for the intrinsic factors is the word tenet. 12, 11, 9, 8, 10. 10 is the destination, 8 is the cofactor for 9. The common pathway and the clot. Both pathways meet at the crossroads, factor 10. This begins the common pathway. Once factor 10 is activated into 10A, it teams up with factor 5, the helper, to turn prothrombin factor 2 into thrombin factor 2A. Thrombin is the boss. Thrombin converts fibrinogen factor 1 into fibrin factor 1A. These fibrin strands form a mesh over the platelet plug, sealing the injury. Mnemonic for the common pathway is 10-5-2-1. Vitamin K and the 1972 rule. Before we get to the labs, look at these little asterisks on the chart. These mark the vitamin K dependent factors. This is high yield for pharmacology and nutrition. Use the mnemonic 1972 to remember them. 10, 9, 7 and 2. Also proteins C and S, but for the cascade, remember 1972. If you are a vitamin K deficient or on warfarin, these steps fail. Finally, how do we test this in a patient? We use PT and PTT. Students always mix these up, but the chart has the perfect memory aids. PT is prothrombin time. PT measures the extrinsic pathway, factor 7. Play tennis outside. Tennis is extrinsic, it is played outside. It's a faster game just like the extrinsic pathway is shorter. PTT, partial thromboplastin time. PTT measures the intrinsic pathway, factors 12, 11, 9 and 8. Play table tennis inside. Table tennis is intrinsic, hence played inside. It has more letters PTT versus PT, just like the intrinsic pathway has more steps. So if you interpret a lab report, high PTT and normal PT means problem is intrinsic. The problem is in factor 8, 9, 11 or 12. High PT or normal PTT problem is extrinsic. It is in factor 7. If they are both high, problem is likely in the common pathway, factor 10, 5, 2, 1 or a massive vitamin K deficiency affecting both sides. Mastering the cascade is all about grouping the spark, extrinsic pathway, the workhorse, intrinsic pathway and the convergence, which is the common pathway. Thrombosis. Virchow's Triad, the holy grail.
You cannot pass pathology without knowing this triad.
3 factors that lead to thrombosis are endothelial injury, stasis or turbulent blood flow, and hypercoagulability of blood. In endothelial injury, which is the dominant factor, the direct injury exposes the subendothelial collagen or tissue factor. Examples are atherosclerosis, trauma, vasculitis. Next is the stasis or turbulent blood flow. Turbulence causes injury. Stasis prevents dilution of clotting factors. Examples are aneurysms, which causes the turbulence, atrial fibrillation, which causes stasis in the atria. And the third one is hypercoagulability of blood. It could be due to primary or secondary causes. The primary are genetic causes, for example, factor V laden mutation or protein C resistance. The secondary is acquired, for example, prolonged bed rest, cancer, Trousseau syndrome, or oral contraceptives. Morphology of a thrombus. How do you tell a thrombus that is a pre-mortem clot from a post-mortem clot? Look at this table. The texture of thrombus or the pre-mortem clot is dry and friable, while the texture of post-mortem clot is gelatinous, chicken fat due to plasma and currant jelly due to RBCs. Thrombus is attached to vessel wall, whereas the post-mortem clot is not attached. The lines of Zahn are present in thrombus, whereas they are absent in post-mortem clot. Lines of Zahn are alternating pale layers of platelets or fibrins and darker layers of RBCs. They prove that blood was flowing when the clot formed. Hence, they are present in pre-mortem clot or thrombus. Part 4. Embolism. This covers our NMC competency PA 6.5. What is the definition? An embolus is a detached intravascular solid, liquid or gaseous mass that is carried by the blood to a site distant from its point of origin. 99% are thromboembolism. Pulmonary embolism. Origin. 95% of pulmonary embolism come from deep vein thrombosis or DVT in the legs, in popliteal, femoral or iliac veins. Pathway. The thrombus travels from leg vein to inferior vena cava, to right atrium, then to right ventricle, and finally to pulmonary artery. The consequence depends on the size. It could be saddle embolus. It blocks the bifurcation of the main pulmonary artery. It causes sudden death due to acute cor pulmonale or right heart failure. Or pulmonary embolism could result in small emboli. They may cause pulmonary infarction or hypertension over time. Let's integrate this vertically with surgery or orthopedics. This is why we encourage early ambulation after surgery to prevent stasis, which could lead to DVT and finally to pulmonary embolism. Other types of embolisms are fat embolism, air embolism, amniotic fluid embolism, The fat embolism is seen 1 to 3 days after long bone fractures, example femur. The features are rash, dyspnea, and confusion. In air embolism, the bends occur. For example, in decompression sickness in deep sea divers. It occurs due to nitrogen bubbles. Amniotic fluid embolism is a complication of labor. The key findings are fetal squamous cells in maternal pulmonary vessels. This leads to high mortality. Part 5. Infarction. This is mentioned in NMC Competency PA 6.6. The definition is ischemic necrosis caused by occlusion of vascular supply. Let's see the table and understand the differences between red versus white infarcts. Red or hemorrhagic infarct occurs where there is dual blood supply or venous occlusion, whereas white or anemic infarct occurs where there is end arterial circulation. The examples of red infarct are in organs like lung or bowel, whereas white infarct occurs in heart, kidney, or spleen. Red infarct, the mechanism is reperfusion or loose tissue allows blood to seep in, whereas in white infarct, solid tissue limits blood seepage. The morphology of red infarct is red or spongy, and in white infarct it is wedge-shaped and pale. Finally, we come to our part 6, which is shock. This is the finale. The definition is, shock is a state of systemic hypoperfusion due to reduced cardiac output or reduced effective circulating blood volume. It results in cellular hypoxia. Classification of shock. Shock is classified as follows. Cardiogenic shock. It occurs due to pump failure. The reason lies within the heart. The causes are myocardial infarction or arrhythmia. Hypovolemic shock. It is due to the loss of fluid or blood. It is seen in hemorrhage or severe burns. Septic shock. It is due to systemic microbial infection, usually the gram-negative bacilli. The mechanism is bacteria release endotoxins, lipopolysaccharides, which leads to activation of macrophages, causing cytokine storm, tumor necrosis factor, and interleukin-1. This leads to systemic vasodilation and vascular leakage, causing hypotension. Stages of shock. Non-progressive or compensated stage, where reflex mechanisms activate, baroreceptors, renin-angiotensin system, and the perfusion to vital organs, that is heart or brain, is maintained. Clinical findings are tachycardia and cool skin. Progressive stage. The tissue hypoperfusion begins. Aerobic respiration switches to anaerobic glycolysis, leading to lactic acidosis. Arterioles dilate, blood pools. Then the third one is irreversible stage. Severe cellular injury takes place, lysosomal enzymes leak. Even if you fix hemodynamics now, the patient will not survive. Acute tubular necrosis in kidneys is common here. Vertical integration with medicine and pharmacology. Septic shock treatment. We fight the cytokine storm and vasodilation with fluids and vasopressors like noradrenaline. In DIC or disseminated intravascular coagulation, which is a complication of shock, especially septic, you bleed and clot at the same time. Let's integrate this with anatomy. The blood supply. Understanding end arteries in the kidney explains why kidney infarcts are white. Hemodynamic disorders are about balance. Fluid balance, edema. Blood flow balance, congestion, hyperemia. Clotting balance, thrombosis. Perfusion balance, causing shock. Read the morphology boxes in Robbins, especially for nutmeg liver, lines of Zan, and red versus white infarcts. These are high-yield image-based questions. I've created a high-yield PDF cheat sheet of all these tables and flowcharts. The link is in the description. Good luck studying.